Just because a patient asks you to treat them with clear aligners does not mean you should do it. General dentists should not be taking on every single case that walks through the door. This is an example of a case that I would heavily consider referring to an orthodontist. I break it down and show you everything that I'm thinking about when I look at these types of cases and the different things that you should also consider when looking at clear aligner cases. I'm Dr. Avi Patel. I'm a general dentist, and we've trained over 200 dentists inside Clear Aligner Advisor. This is one of the doctors in our program. They shared this case with us, and I hope you get some value out of this. All right, so this is a very interesting case. I would not necessarily be jumping at the bit to start a case like this, but I want to use this as a way to just walk through what I'm seeing, changes I would make, things I would consider, so that way we can get a good result. So for this case, if we're just looking at it and trying to classify it, we have got, let's see here, we've got some crowding on the bottom, and we've got spacing on the top, and we've got some interesting stuff going on here where there are some missing teeth, right? So these are pontics. So these are not actually in the mouth. This is something that the simulation is actually placing to fill the space. And I will say something about that in a bit, but let's see here. Okay. So I like to look at the relationship here. So obviously we're missing this first molar there. So tough to classify that, but yeah, so you've got some interesting going on here with the molar relationship. So, missing a maxillary first molar, missing a mandibular first molar here as well. And on this left side, we have got almost like a class 3 molar relationship, just going off of the second molar relationship. And on the right side, we've got a class 2 molar relationship going on. Definitely first sign of this being a little bit of a funky case. The other thing is whenever you've got unlike arches, so in this case, you've got the spacing on the maxillary arch and crowding on the mandibular arch, it is going to be a sign that you are going to need to really think of, because these cases can be tricky since all this is space management. And so you have to decide, are you going to make so what you have to do is you have to figure out how you're going to make these arches fit. You've got too much space on the top arch, and then you don't have enough space on the bottom arch. And you're going to have to move the space around to find that happy medium. And so on the bottom, as you can see through this plan, there's a lot of IPR going on here. So the plan here is to try to create some space by doing IPR. And then on the maxillary arch, the plan initially is to basically remove the space, bring everything back in together. And let's see here. Yeah, I am looking at this, and my first thing would be like, this is a significant amount of IPR. Significant amount of IPR to be doing. My question would be, are you comfortable doing posterior IPR 0.5 millimeters like this? Me personally, I am not. I like to stick to anterior IPR. I think it's just more predictable. And so you would have to be doing IPR in several areas here. And looking at the maxillary arch, this is not IPR. These are actually spaces. So the green squares, when they appear, are actually just showing you how much space you have between the teeth. And so when you look at that, so that is what's going on there. Now, we've got some comments and we've got some updates to the treatment plan. Just looking at this, I would say attachment-wise, so this attachment... So I don't like these attachments here on the laterals because they are not predictable and they don't really help. This optimized attachment, half moon on the marginal ridge of the tooth, does a corkscrew movement for the laterals, not very predictable. I like to get some lateral retention attachments on there just like this. We can make those even bigger if we'd like. Those are really good at getting the movement that we want. I see here we've got some horizontal beveled attachments. Those are great on the premolars for anchorage. And on this side, same thing, horizontal beveled, great for anchorage. We got this one in for rotation. This one, so an optimized anchorage attachment for incisor retraction. So what this does is, since we are retracting these teeth, I'll play this out for you, and you're bringing them back. What that's doing is this attachment is placing a counteractive force on the molar to prevent it from moving to the mesial. If you don't have this attachment, then as the trays are trying to retract and basically bring these incisors to distal, and you are going to naturally have these molars try to move forward. And so this attachment just prevents that from happening. If that does happen, you will get a posterior open bite and you will not be able to fix it. That is absolutely one of the hardest things to actually correct. You can ask anybody. And so this is a good attachment to have to prevent that from happening. The next takeaway that I would have here is these pontics. So you've got these pontics here, and aesthetically, sure, it's great because it looks like there's a tooth there. But personally, I like to have no pontics when there are spaces, because I would much rather have the trays hugging these teeth. Because if this pontic is gone, you're going to get more plastic wrapped around this molar on the distal or on the mesial, and more plastic wrapped around the distal of this premolar. And so that way you actually have more control over the tooth. And same thing down here. So I would request to remove these pontics, and that way the plastic can just fill in the space and you get more surface area on those teeth. So that's what I would do there. The next thing, looking at this case, I see how this premolar is positioned, and to try to move this premolar 48 degrees, to try to rotate it 48 degrees, that's pretty significant. It's possible, but then I think we have to ask the question, is it necessary? So what are we gaining by rotating this premolar? Because for this patient, considering their age, they already have a stable occlusion in that regard. And so trying to get this premolar to rotate could be a bit excessive. And so I say that because what you want to do is you want to do movements that are going to improve the situation. And so if we're gaining space or there's some other benefit by rotating this in, by all means do it. If there's not any main benefit, then I would say maybe we keep it as is. And I don't know what the long-term plan is restoratively for this, but you're starting off with 6.6 millimeters of space between those teeth, and you're getting 7.3. So if you are trying to place an implant here and you need that much space, sure, you can go for it. But if 6.6 millimeters is enough space for you to drop an implant in here and close that space, I would much rather do that and then use this purely as an anchorage movement, because anytime you try to rotate this tooth, you have to remember that's going to take forces away from other teeth. So that is my take on that. I can see here that changes were made to some of the IPR. It's been reduced in this area. We still got significant IPR going over here. So again, you got to be comfortable doing that much IPR. The other thing to take into account is when this is all said and done, you are running on this. To me is a very tight finish. So you're not getting, doesn't really seem to be a lot of clearance there. And it's saying we've got 2.3 millimeters of overjet, but 0.9 millimeters of overbite. And that to me is not, that to me is just too tight. I would want 1.5 millimeters of interincisal clearance. I don't think we have that just by looking at this. And so I would request that we get that, because if we don't have that clearance, what you're going to run into the risk is these teeth touching prematurely. And if the anteriors touch prematurely, the risk of a posterior open bite goes up through the roof. So that is something that I would take into consideration. Also, just know that based on where you're starting and where the projected finish is, you are most likely going to need to keep some space, probably distal. You have to decide, do you want to do it distal to the canines? Do you want to do it between the laterals and then go in and close those restoratively, right? Because you've got a tooth size discrepancy here. So to try to retract that and then create all that space on the bottom, very difficult. I think this is going to be an ortho restorative case if it's something that you do decide to take on. And yeah, I think that is something that I would look at and think about. So like I said, a lot of questions here that you got to answer. What I do like though is I like these bite ramps. So they're on the canines and they're on the incisors, centrals. And I like that because They are not on the laterals because, as you can see here, the laterals are rotating. And so we are having those bite ramps go over to the canines instead of the laterals. So that's very good. But yeah, personally for this case, I would consider referring to an orthodontist just to get them to manage it and then going in and fixing it restoratively, just due to the nature of this case and having to manage it. Again, if you would like to proceed, you totally can, but I would take into account those considerations and use that as a determining factor in terms of how you're going to proceed with this case. One more thing I will say is there is molar movement occurring. And so personally, I would like to remove that. If you have a lot of that molar movement going on, it's not going to be the most predictable thing. So yeah, that is my take on this. If you found any of this stuff valuable, I have so much more where this came from. There are a couple options. We've got free trainings. Check those out in the description below. We also have paid courses in there. But if you don't want any of that and you just want to hang out here with me, just go ahead and check out this video. I put it together. It goes over deeper clinical principles all around aligners. You got to check it out. I'll see you in there.